Hello, everyone. I am Camille Kotton, and it's a pleasure to be with you today. I am the Clinical Director of Transplant, Infectious Disease, and Immunocompromised Host Program at Massachusetts General Hospital, also Associate Professor at Harvard Medical School in Boston, Massachusetts. Risk factors for CMV after solid organ transplant include many different factors, but perhaps the most important one is the serologic CMV status of both the donor and the recipient. When the donor is CMV positive and the recipient is CMV negative, that is the highest risk factor for people developing active CMV after solid organ transplant. After that, there are many other factors that play in. I will say that having both a donor and recipient that are both CMV positive is another risk group. Fortunately, in the rare instance when both the donor and the recipient are both negative for CMV, that gives a very low risk for developing CMV, except when there is potential for exposure to CMV through factors such as transfusion of blood products. There are many other issues that can contribute to the risk of CMV, and that includes allograft rejection, especially with intensification of immune suppression, severe lymphopenia, which we sometimes see either due to induction therapy, ongoing medications, chronic medical issues, and such, as well as more intense immune suppression, perhaps people who are highly sensitized, perhaps if they've undergone a prior transplant, multiple other similar factors where there would be an intensification of immune suppression. Also, HLA mismatch usually results in higher levels of immune suppression, so higher risk of CMV. And then interestingly, other concurrent infections can contribute to the risk of developing CMV, and also CMV can contribute to the risk of other concurrent infections, such as viral infections, bacterial infections, fungal infections, and even post-transplant lymphoproliferative disorder. There are also genetic polymorphisms that seem to contribute to the overall risk of developing CMV. I will say that those are things that we're not necessarily using clinically at this point, but that we do think about and that certainly have been described more in research settings. I think that sometimes those explain some of the patients who have more complex, sometimes even resistant refractory CMV or really highly problematic CMV, and I think we all are familiar with those patients. Also, it seems that the transplanted organ can contribute to the risk of CMV. We tend to see higher rates of CMV in lung transplant recipients, small bowel recipients, composite tissue recipients, and then overall lower rates of CMV in perhaps the more common transplants, but liver and kidney transplant. So just in sum, it's important to realize the risk factors for CMV after solid organ transplant. And then when you're thinking of those risk factors, incorporate that into prevention strategies as far as who's at higher risk and then lower risk. There are two main strategies that are used to prevent CMV in solid organ transplant recipients. The first is a preemptive approach, which is where for the first 8 to 12 weeks after transplant, weekly CMV, either viral load or antigenemia, is checked. And then once a certain threshold is reached, and that is defined by local practice, local testing, institutional guidelines, then treatment dose antiviral therapy is started. An alternative would be prophylaxis or universal prophylaxis, where either a high-risk group or multiple high-risk groups are given antiviral prophylaxis for a predefined period of time, often 3 months or 6 months. These are both strategies that we discuss in the International Consensus Guidelines on CMV Management after solid organ transplant. There are sort of risks and benefits of both approaches. I will say that with prophylaxis, we see very rare early CMV disease, but higher rates of late disease. Both are very good at preventing CMV overall. So both are really good approaches. We do see higher rates of late CMV when we end prophylaxis, and that's something that we don't usually see with preemptive therapy. So that's something to consider. In the guidelines, we do talk about a hybrid approach where we do prophylaxis, and then in people who seem to be at higher risk for developing CMV, some of the factors that I mentioned before, higher doses of immune suppression, D plus, R minus, serostatus, etc. People with low absolute lymphocyte count, we do recommend doing preemptive therapy at the end of prophylaxis as a means to capture those high-risk patients before they develop into florid active CMV infection. Something to take into consideration is what your own institution can actually do on a regular basis. So it's a lot easier to do prophylaxis and just to give it for 3 or 6 months. A preemptive therapy approach requires weekly testing, so the patient must be willing to go to a local laboratory or the institutional laboratory every single week without fail, and then those test results need to be followed up upon and then treatment initiated once a certain threshold is reached. There's a lot of discussion about cost for both of these, and certainly drug costs are higher with prophylaxis. Testing costs are higher with preemptive therapy, so you have to think about your own individual transplant center and what the best approach would be for each of those. There are multiple other factors to take into consideration as well, and I would ask you to think about issues like resistance, which seem to be relatively the same. Also, the fact that you're not necessarily preventing other human herpes viruses if you're doing preemptive therapy. And we overall think that safety, prevention of rejection, and graft survival is probably similar with both approaches. There are several different treatment options for active CMV, and for over 2 decades now, we've had ganciclovir and valganciclovir as the real workhorse, both for prophylaxis but also for treatment. The most common adverse event would be myelosuppression, especially low white blood cell counts. And it's really important to know the true renal function when you're calculating the appropriate dose. Foscarnet is also something that is used, but there are significant rates of nephrotoxicity and electrolyte wasting. We usually reserve this for either resistant refractory disease or for people that have deep neutropenia, especially after stem cell transplant. Maribavir is a new agent that is largely used at this point for resistant refractory disease. It's an oral drug. In general, it's well tolerated, although in the clinical trials, close to half of patients developed dysgeusia or an abnormal taste. And there can be some drug interactions with things like tacrolimus, so drug monitoring is necessary. Other drugs, such as cidofovir, are rarely used. They can cause nephrotoxicity, a Fanconi syndrome, and ocular toxicity. And so we really reserve that for extenuating circumstances. And then immunoglobulins are something that can also be used, either intravenous immunoglobulin or CMV immunoglobulin, which is really just intravenous immunoglobulin that's enriched for CMV positive donors that have higher titer CMV IgG. With immunoglobulins, we can see nephrotoxicity, thrombosis, hemolysis, and sometimes trolley. And so worthwhile monitoring those patients. We wouldn't usually use immunoglobulins alone, but often, especially in the setting of resistant refractory disease or severe CMV, with some of the other antiviral agents that I mentioned. The implications of antiviral resistant refractory disease can be significant. We don't see this very often in solid organ transplant recipients, but when we do, we know that resistant refractory disease conveys a much higher risk of significant morbidity and also mortality. So it's really important to do careful management. I will say that we tend to see this more when you have either malabsorption of prophylaxis or treatment antivirals, or if low dose or mini dosing is used for prophylaxis. So that should really be avoided. When you suspect that you have clinically resistant or refractory disease, if it is mild to moderate disease or even asymptomatic but significant viremia, we would recommend that you switch to either full dose intravenous ganciclovir or higher dose, what would usually be 7.5 to 10 milligrams per kilogram every 12 hours, and then adjusted for renal function. However, if there is severe disease, life-threatening disease, sight-threatening disease, we would recommend switching to foscarnet, although now we have the possibility of switching to maribavir, which is an oral drug with less toxicity, as shown in the recent phase 3 trial, compared to foscarnet and other similar agents. However, it should not be used if there is ophthalmologic or CNS disease. We would then recommend sending genotyping to see if there's a UL97 or UL54 mutation. And then based on those test results, we would then recommend the next steps. If no mutation is found, you could certainly continue with full or higher dose intravenous ganciclovir. And then if a mutation is found, it's important to consider what the resistance conveys. Does it convey high level ganciclovir resistance or lower level? If it's lower level ganciclovir resistance, you can certainly continue with the intravenous ganciclovir at either full or high dose, or you could switch you should switch if the resistance conveys high level resistance to either foscarnet or maribavir. Again, maribavir should not be used if there's ophthalmologic or CNS disease. And generally, treatment is then continued for several weeks at a minimum. Maribavir was actually tested in the phase 3 trials for 8 weeks of treatment, but usually until there is a strong clinical response as well as a significant decrease in the CMV viral load. Usually we like to treat people until there are 1 to 2 test results that are either negative or very low using one of the newer ultrasensitive assays as per the CMV guidelines. And then if there's no improvement in viral load after 3 weeks, it's good to repeat the genotyping for resistance and consider additional non-standard or experimental treatments. You can actually circle through what I had already outlined, especially because sometimes people acquire new resistance over the course of time. And I'm excited to share with you that we have developed this online calculator for resistant refractory CMV in transplantation, and it's called this Clinical Decision Support Tool. And basically, it walks you through the algorithm that I just described for primary management of resistant refractory disease, but it allows you to enter the data from your patient and sort of guides you down the appropriate therapeutic pathway, which I personally have found this to be quite helpful. When things get complicated, it does recommend that you discuss the case with the transplant infectious disease specialist, because this is fairly complex management. But nonetheless, I hope that you too find this helpful.
My name is Dr. Raymund Razonable. I am a professor of medicine at the Mayo Clinic in Rochester, Minnesota. And today we will be talking about the treatment of refractory and resistant CMV in solid organ transplant recipients. Maribavir is a novel antiviral drug that has recently received FDA approval for the treatment of refractory and resistant CMV disease. It acts by acting on UL97, preventing viral encapsulation and egress, a mechanism of action that is completely different from the traditional standard antiviral drugs such as ganciclovir. It has been shown in phase 3 clinical trials to be better compared to ganciclovir or foscarnet in patients with refractory resistant CMV disease. In this trial that was conducted in 350 patients, the time to viral clearance is faster and at higher rates among patients who receive maribavir compared to those who received drugs that were chosen by investigators, which is most commonly ganciclovir and foscarnet. At the end of 8 weeks of treatment, there are about 55% of patients who achieve clearance of viremia among patients who receive maribavir compared to only about 24% among patients who receive ganciclovir or foscarnet. In addition, it was safer. There was less amount of nephrotoxicity when compared to foscarnet, and there is also lower incidence of neutropenia when compared to ganciclovir. Accordingly, the results of this study had led the way for its approval, and it is now part of the standard armamentarium for the treatment of solid organ transplant recipients with resistant or refractory CMV. Foscarnet has been the standard drug for the treatment of refractory and resistant CMV, especially for those patients who develop CMV that has resistance to ganciclovir as a result of a UL97 mutation. Foscarnet acts on UL54 cmVDNA polymerase and therefore is effective in UL97 mutant viruses. While it is effective in reducing viral load, it is often associated with a lot of toxicities. More often, patients are required to stay in the hospital for intravenous infusion 2 to 3 times a day. There's a lot of electrolyte abnormalities that has to be managed during the time of intravenous administration. And at the same time, there's also a high risk of renal dysfunction. Approximately about 50% of patients may develop renal toxicity at the end of treatment. In a study conducted in about 39 transplant recipients, including solid organ as well as stem cell transplant recipients, it has been shown that 50% of patients will develop toxicity at the end of treatment, and in about 30%, this persisted up to about 6 months after therapy. There is about 30% relapse rate after clearance of viremia in patients who have completed foscarnet therapy, emphasizing the need to also optimize the immune system to ensure persistent cure in patients with CMV disease. Letermovir was approved by the FDA for the prevention of CMV in stem cell transplant recipients. However, it does not have any active indications yet outside of prophylaxis, and it is not indicated for treatment. However, because it acts at a different mechanism of action by inhibiting the viral terminase, letermovir has been used off-label outside of the FDA indication for the treatment of refractory and resistant CMV. This has been demonstrated in several case reports and case series, suggesting that it could potentially be effective in reducing viral load as well as in treating CMV diseases. It is important to point out, however, that this is not an approved indication, and if you look at the reports, there appears to be low barrier for resistance. This is important to emphasize, particularly as patients often have very high viral loads. It is not uncommon for those patients to develop resistance to letermovir, thereby rendering this drug ineffective in the long term. Immunoglobulins in the form of CMVIG or the usual IVIG has been suggested as an adjunct treatment in combination with antiviral drugs in patients who are high risk, such as lung transplant recipients or stem cell transplant recipients, when they develop severe CMV disease, such as those with severe pneumonia, for example, as well as those with CMV encephalitis. Outside of those clinical syndromes and high-risk patient populations, it generally has not been used for treatment. It is generally well tolerated. However, it could potentially be associated with increased risk of nephrotoxicity. There's been reports of thrombosis. There's been reports of hemolysis, as well as acute lung injury in patients who receive high-dose IVIG or CMV immunoglobulin. Nonetheless, in patients with refractory or resistant CMV, this is a potentially useful adjunct therapy, particularly in patients who are CMV seronegative to start with, and it is used in combination with established antiviral drugs.
Hello, I'm Dr. Genovefa Papanicolaou. I'm an infectious disease physician at Memorial Sloan Kettering Cancer Center in New York. Today, we will be talking about best practice in the management of refractory or resistant CMV infection in solid organ transplants. Well, let's start with the example of a patient. This is a 45-year-old recipient of a kidney transplant, and the CMV DNA screening value was 1,100 international units per ml in 2 consecutive tests, separated by 2 days and determined by the same specialty laboratory. The patient has been receiving treatment with ganciclovir. So first, I'd like to ask a few more questions to guide management. I'd like to know for how long has the patient been on ganciclovir or valganciclovir. For example, if the patient has been exposed to this drug for 4 to 6 weeks, and currently he is being treated for CMV with induction dose valganciclovir for 2 weeks or more, then I believe that we should test for resistance so that we can better optimize the management of the patient. Now, mutations in CMV arise after prolonged treatment with a medication or due to suboptimal exposure. So in situations that the patient is skipping doses, or if the physicians reduce the dose because of renal insufficiency or because of side effect of neutropenia. And the mutations that confer resistance to CMV can be in 2 different genes. The first gene is the thymidine kinase UL97. This is essential for phosphorylation of ganciclovir into an active form. And these are the type of mutations that appear first after prolonged exposure of ganciclovir and account for about 90% of resistant cases. Now, mutations in UL54 tend to appear later, and only if the patient has seen multiple antivirals. The UL54 gene is the DNA polymerase gene, and mutations in that gene can confer resistance to multiple antivirals. Until very recently, we had just 2 antivirals for CMV, mainly ganciclovir and foscarnet. Ganciclovir also comes with its oral prodrug, valganciclovir, and the main limitation is neutropenia, or in general myelosuppression. So up to 30% of patients may experience neutropenia with valganciclovir, which is dose dependent and exposure dependent. And that is the main problem with valganciclovir or ganciclovir. Now, an alternative treatment option is foscarnet. Foscarnet comes only as an intravenous infusion and is nephrotoxic. So particularly with in patients with pre-existing renal failure, it can be quite problematic to give. Foscarnet also causes electrolyte wasting and therefore requires very aggressive electrolyte replacement. And also hydration that is required to limit the kidney injury due to foscarnet necessitates very prolonged infusion time. So foscarnet is very intense in utilization of health resources such as infusion clinics or sometimes hospitalization, and also from the part of the patient. Patients have to stay tied to an intravenous infusion for many hours a day. Now, the alternative treatments that we have, recently we have the approval of maribavir for resistant and refractory CMV. So maribavir is a new antiviral that is orally bioavailable and it doesn't have myelosuppression or nephrotoxicity. The main side effects are taste disturbance that usually happens shortly after taking the drug and can last for either a short time or many hours. Very rarely patients have to discontinue maribavir because of that. And other some potential side effects are nausea and vomiting. Now, letermovir is a medication that is approved for prevention of CMV in stem cell transplant patients. However, sometimes it is used for treatment in extremely refractory CMV cases that do not have any other treatment options. It can be used. It's not recommended really, but it is extremely safe and doesn't have much toxicities. So our patient was tested and results came back and revealed resistance mutation in the UL97 gene. So mutations in UL97 confer resistance only to ganciclovir or valganciclovir, and not to any other CMV antiviral. Now, there are two types of mutations. Some confer low-level resistance to ganciclovir, and those can be overcome by increasing the dose of ganciclovir. So instead of the usual dose, we double the dose up to 10 milligram per kilogram twice a day, of course, adjusted for renal function. If the UL97 mutation confers high-level resistance, usually those would be above tenfold in the IC50 of the virus, then ganciclovir is not going to work. We need to switch the class, and we can talk about switching class with the currently approved medication maribavir, which is recently got FDA approval for resistant or refractory CMV. It is a UL97 kinase inhibitor. However, it doesn't have cross-resistance with ganciclovir, at least for the most part. It is given orally and dosed at 400 milligrams twice a day. So that would be one alternative. There are off-label treatment options. The ones that we are most familiar with is foscarnet. Foscarnet inhibits DNA polymerase, and it is active against strains that have UL97 mutations. Ganciclovir is given intravenously and can be nephrotoxic. Now, I will also mention that in certain cases, we have seen the use of letermovir for treatment of CMV. Letermovir is a terminase inhibitor that is approved for prevention of CMV in stem cell transplants, and trials are ongoing for prevention of CMV in kidney transplants. And so letermovir should not be used for treatment of CMV because of low barrier to resistance. However, sometimes in desperate situations, we see that used. Letermovir is really safe, and there are not major side effects that have been observed. And just back to our patient, the patient was receiving valganciclovir. However, the valganciclovir dose was reduced because of neutropenia. And it is possible that resistance emerged because of a suboptimal exposure. Now, because of this dose-limiting toxicity, the patient needs an alternative treatment. If maribavir is available, I would go with maribavir just because it is easier to give, is orally bioavailable, and does not have myelotoxicity or nephrotoxicity. In situations if maribavir would not be available, then we would have to use foscarnet. So when we think about treatment, we need to think of patient factors, viral factors, and transplant factors. So first, going back to our patient, I would like to know the donor and recipient serostatus. Donor positive, recipient negative patients are at highest risk for CMV related complications, and really that combination also negatively impacts graft survival. Then we would have to look at the immunosuppression of the patient. Has the patient received a lot of additional immunosuppression for rejection episodes? Is there any way to reduce immunosuppression? Because that would help with resolving its CMV with the additional antivirals. And then we need to look also at the severity or the site of CMV disease. For example, if the patient has CMV retinitis or CMV encephalitis, maribavir is not a good option because it does not have penetration into the central nervous system. So an alternative option would be needed there. Now, some kind of pharmacodynamic factors, therapeutic drug monitoring, of course, it would be important to know that the patient is getting optimal exposure. Therapeutic drug monitoring for ganciclovir is not routinely used in the United States. However, we make every effort to ensure that the correct dose is given, that the patient is compliant, and the patient can absorb well the medication. Now, if the patient continues to have persistent viremia, it is important to keep in mind that additional mutations can emerge, and therefore repeat genotypic testing is indicated if the patient doesn't respond into the according to the changes in management that we first did. And of course, additional treatments currently, there are a lot of things that we don't know. For example, a combination of antivirals and or other experimental treatments such as adoptive T-cell therapy that at this point are not routinely available.